This is a case presentation about a 52-year-old male patient with a history of hypertension. The patient had tearing chest pain after lifting a heavy item at work around 4 p.m. the day before presentation. Pre-op CT scan showed a type A aortic dissection with intimal tear in the ascending aorta, which extended into the right lower extremity with near occlusion of the right external iliac artery. All the visceral vessels came off the true lumen except the renal artery. A midline sternotomy was carried out. The innominate vein was isolated and encircled with an umbilical tape. The right innominate artery was exposed and encircled with a vessel loop. The pericardial valve was created. Trio purse-ring suture was placed on the right atrial appendage and two plegited trio on the distal ascending aorta. The aorta was accessed with a needle. True lumen access was confirmed with TEE. A 22 French arterial cannula was inserted over the wire using the Seldinger technique. The right atrium was cannulated with a multi-stage venous cannula. A left ventricular vent was inserted into the right superior pulmonary vein. Cooling via cardiopulmonary bypass was initiated with the goal to cool to 24 degrees. We started mobilizing the aortic arch. The left common carotid artery was fully dissected out and encircled with a vessel loop. The distal ascending aorta was cross-clamped and the aorta was cut and transected in the mid-ascending position. An intimal tear was noted in the proximal ascending aorta. Cardioplegia was administered through the left and right coronary ostium. There was extension of the dissection into the right and non-coronary sinuses. The root tissue was aneurysmal and thin. The aortic valve was inspected, had good coaptation, suggesting feasible repair with root replacement. The left and right coronary buttons were isolated, leaving a 5 to 8 mm rim of aortic sinus above the base of each cusp. The height of the interleaflet triangle was measured, and a 30 mm Valsalva graft was chosen to reconstruct the root. Plegited sutures were placed above each commissure. 6 subannular plegited 2O sutures were placed, one at the base of each commissure and one at the nadir of each cusp. The subannular sutures were placed through the graft. The graft was trimmed to an appropriate length, and the commissura stitches were brought through the inside of the graft. The graft was tied down over a 27 mm sizer. The three commissures were resuspended inside a Valsalva graft at the new sinotubular junction by bringing the furrow-pleated sutures through the graft. By this time the patient had reached 24 degrees. Circulatory arrest was initiated and the cross-clamp was released. The aortic cannula was removed and the aorta was excised to zone 2. The innominate artery and the aortic arch were dissected, but there was no intimal tear noted in the aortic arch. Decision was made to perform a zone 2 arch replacement. Catheters were inserted into the innominate and the left carotid artery. Bilateral selective antegrade cerebral perfusion was initiated. A Zone 2 arch graft was prepared and trimmed with a 3 cm distal landing. This was anastomosed to the Zone 2 arch with a running 4-row suture, incorporating a felt strip external to the aorta. After the anastomosis was completed, a sidearm of the graft was connected to the arterial line, and lower body perfusion was initiated. The graft was de-aired, and a cross-clamp was applied just proximal to the first sidearm. Each arm for the head vessels were clamped with hemostats. Rewarming to 32 degrees was initiated. Attention was turned back to the aortic root. The hemostatic suture line was performed in the three sinuses, using running 5-0 sutures, starting at the nadir of each cusp. Once the hemostatic suture line was brought to the top of each commissure, the sutures were tied to each other. The valve was saline tested and appeared competent. An ophthalmic cautery was used to burn a hole in the left sinus of the graft, and the left coronary button was anastomosed to the graft using a 6-0 running suture. The same technique was applied to the right coronary button. Cardioplegia was administered down the aortic root to assess for hemostasis of the suture line and coronary buttons, as well as valve competency. The grafts were trimmed to appropriate length, and end-to-end anastomosis was performed using a running furrow suture. The heart and the graft were de-aired through a cardioplegia catheter. The cross clamp was removed. The cardioplegia catheter was removed from the left common carotid artery, which was then clamped with an angled DeBakey clamp and trimmed proximally. This was anastomosed to the second 8 mm head vessel arm of the graft with a running 6-0 suture and was de-aired. The same technique was used for the innominate artery, which was anastomosed to the first 14 mm head vessel arm of the graft with a running 5-0 suture. After rewarming, the patient weaned from cardiopulmonary bypass with ease. The right atrial cannula was removed. The enterflow sidearm was doubly ligated with 2 heavy silk ties, 2 large hemoclips were applied, and then it was cut. The chest was closed with 6 double sternal wires, and we performed standard closure. Post-op echo showed good left ventricular function and good AV function. Post-op CT scan showed a well-seated root reconstruction. The ascending aortic graft was widely patent and without kink. The supraaortic arch vessels were widely patent. The previously noted near occlusion of the right common iliac artery was present, but the patient had no symptoms. The patient's postoperative course was uneventful. He was extubated on postoperative day 2 and discharged home on postoperative day 11. Thank you for your attention.